Good evening, everyone. Thank you so much for joining us for another installment of our Critical Conversations webinar series. It's good to be back. We took a little break for the summer, but I am really excited about tonight's topic, and I could tell from the number of people registered that you are too. I think that, a lot of the reason that we started SC Red was the fact that reproductive and maternal health was just falling under the radar as it relates to individuals with sickle cell disease. And, I do a lot of these webinars and I kind of go into them feeling like I know enough, but I can say that contraception is really one of those topics that I'm really excited to have this conversation tonight and learn together with all of you. So I'm going to stop talking and introduce you to our presenters tonight. So I have Dr. Maayan Leroy-Melamed. She and I go back quite a ways. We've published together, we've done some panels together, and she has just been such a valuable resource. She is an adolescent medicine specialist. And then we also have Dr. Andrea Roe, who is an OBGYN at Penn. And just unfortunately, we live in the kind of climate where we just have to protect her identity. So that's why she's not on camera tonight. But we're excited to have this conversation. So Dr. Leroy-Melamed, let's get this going.
Hello, everybody. My name is Maayan Leroy-Melamed, and I am an adolescent medicine doctor, which means I'm a pediatrician that spent an extra 3 years studying teenage issues like contraception. And my research interest is in sexual and reproductive health in adolescents and young adults with sickle cell disease. So I'm very excited to talk to you about contraception and sickle cell disease today. And part of Dr. Roe's help is going to be in skewing a little bit more adult because I have an adolescent focus. Also, just so you know, I gave a version of this talk to the New England Sickle Cell Consortium and adapted it for this audience. And a lot of the language I left as being more medical, and happy to clarify as appropriate. All right. So the objectives of this talk are to define reproductive justice and its application around people with sickle cell disease, recognize barriers to reproductive choices in sickle cell disease care, identify referral pathways for prenatal and contraceptive care, assess common contraindications and side effects of specific contraceptive options, weigh the risk and benefits of injectable contraception in the context of sickle cell disease, and apply the best contraceptive options in consideration of sickle cell disease. So just to introduce the reproductive justice framework that emphasizes human rights, including the right to have a child, the right not to have a child, and the right to parent the children one has in safe and sustainable communities. We all know the history of sickle cell disease and coercive contraception. And as providers, we're making efforts to forward fertility. And the focus of this talk is contraception for people who want to prevent pregnancy. I think that I don't need to explain the complications of that to anybody in this room. Happy to discuss it further at the end if there are questions about it. But I suspect that people want to, people know about it already more than I do. Of course, I forgot to pull up the poll everywhere before we signed in. I apologize. I hope to be able to do that very quickly right now. And of course, the password is it. But basically, prepare, please, one word to describe your experience with contraception. And we're going to plug it into a word cloud. And okay, sorry, guys. I'm going to present. Share this tab instead. Okay. All right. So you can go to Poll Everywhere and type in my name, and hopefully there will be responses, ideally. Should have had Tiana test this first.
Should we scan that QR code?
Yeah, you can scan the QR code or you can type it into your browser.
Okay.
Is it working?
Not for me.
Oh, it'd help if I activated it. Gosh darn it.
Oh.
All right, guys. Okay. Great start. Okay, hopefully it works now. You can also join by text.
Okay.
Is it working?
No.
Cool.
Maybe we can come back to
it. It's working. It's working. It's working. Responses are coming in. Okay.
It is working. Okay.
Okay, limited experience. Fair enough. All right. I'm going to give it another minute and hope that it works because I really want to know who's out there and what they're thinking. Okay, awesome.
It works for me. Patricia, what is she supposed to type into the browser?
A word or two you might use to describe your into the browser, polev.com/Maayan Leroy-M847.
And if you have your phone handy, it might be easier to just scan the QR code. It will take you to the same place. Oh, I love these responses.
So I'm glad it worked.
Oh, wow. Inconsiderate. Some of them are heartbreaking.
Okay, maybe we can come back to this afterwards and we can see more responses in a couple of minutes, but you guys can keep on responding if you can get to it. Take your last scan. Just as a background, this is again more for the provider standpoint. Again, if you have sickle cell disease, you are probably more than well aware of this. The unintended pregnancy rate is sort of controversial. It is not that discrepant from the unintended pregnancy rate for matched ages. There is a 56% pregnancy rate by age 21. And there is a greater risk of maternal and fetal morbidity and mortality, 26 times greater than the non-Black age matched population. And there's part of that risk is due to thrombogenicity during pregnancy. And there's also a concern that for people who do get pregnant unintentionally, if they're on teratogenic medications, which may or may not include hydroxyurea, unclear, the risk is unknown. And then there's also the challenge that hematologists are acting as primary care providers for a lot of people. A lot of the adults with sickle cell disease I know don't have a primary care provider, so it's unclear who's evaluating for the need or desire for birth control. And then, a lot of people are on Depo, as the title of this talk indicates. 2 studies have shown that Depo, medroxyprogesterone, acetate, DMPA, or injectable contraception, which I'll call Depo from now on, improves anemia and sickle cell crises. 2 other studies in other populations, not specifically to sickle cell disease, showed an increased risk of venous thromboembolism or blood clots with Depo. And there are other concerns for Depo specifically, including weight gain, bone mineral density, and return to fertility. So I think hematologists often have the approach of like, okay, Depo's been studied, let's use it for everybody with sickle cell disease. And that is obviously limited, as one of you guys indicated. So what are people actually using? in the United States, condoms and withdrawals are the most common option. And in general, the pill is the most common in the adolescent age group that I work with, followed by emergency contraceptive, Depo, and then other methods. So are pills the answer to everything? So the review I'll give briefly of hormonal contraception. In general, the typical birth control pill contains two hormones, estrogen and progestin. Estrogen inhibits follicle-stimulating hormone and luteinizing hormone and inhibits ovulation. And the synthetic progestin is an analog to the human progesterone, which thickens cervical mucus to prevent sperm penetration and inhibits capacitation of sperm. So basically makes the sperm not be able to meet the ovum. And it combines and the combination of estrogen and progestins are in oral contraceptive pills, the contraceptive patches, and the intravaginal ring. So what about pills in sickle cell disease? The problem in the general population is that it increases the risk of venous thromboembolism or blood clots 3 to 4 times in the general population, which at baseline for a teenager without sickle cell disease is about 1 in 1,000. So the risk of about 3 in 1,000 is not super high. A study in sickle cell disease patients 2023 showed that about 1/3 of people are using pills even more than Depo. And there was one in that study, they did not show a significant increase in blood clots except with the patch, which may have had an increase. And if we're looking on the other side of it, pregnancy increases the risk of clots by 40 times as opposed to those 1 to 3 times that we talked about. And then there are other benefits of the combined pills, including acne, especially for teenagers. But when we think about in sickle cell disease, it's being seen more as an inherited thrombophilia, which means that people are at baseline high risk of blood clots from birth, and then as the risk for the general population increases with age, so does the risk for sickle cell patients for clots exponentially as well. So when doctors look for guidance, they often use the CDC medical eligibility criteria, which was recently updated. So there's little evidence on any of the methods specific to sickle cell disease. And when you look at the pills, it's listed as a category 4, which is an unacceptable health risk. But until this year, the CDC indicated that benefits outweigh the risks, but there's no increased evidence of blood clots in general. We're just thinking of sickle cell disease differently in terms of blood clots. Medicaid data has shown in the past that people were using combined birth control pills very often. As the most common, but I think probably the tide is shifting a little bit because we're worried about blood clots in sickle cell. And I think it's a really individual decision that depends on a discussion with your doctor. For example, if you're already on blood thinners because of other concerns, then the risk of a blood clot is very low, and that might be a discussion that might be worth considering. And then if you look at Depo, just to go back for a minute, there's like a rating system with the medical eligibility criteria where 1 is considered generally low risk, 2, advantages generally outweigh the theoretical or proven risks, and 3, the theoretical or proven risks usually outweigh the advantages. And Depo's listed as a category 2 or 3, unclear, and that may be maybe due to the applied risk of blood clots. There's also a potential risk of osteoporosis, and the risks and benefits are unclear. So it's sort of because of those shown benefits to decrease periods and pain crises. So it's really unclear. And Dr. Roe had some recent data from Pennsylvania that showed that Depo is more common use, and the IUD is also becoming more common in this population, followed by permanent contraception and condoms, and the pill is becoming much less common. which is becoming more different from the general population. So, and this is just I'm going to briefly overview the different types of birth control and remind everyone again that any hormonal birth control will improve dysmenorrhea. And we'll talk a little bit later about why that matters, and a lot of, actually, I'll just plug this now. So I just submitted a NIH Career Development Award with Tiana's help to study menstrual health in adolescents and young adults with sickle cell disease. And part of that is because of what we see as increased rates and decreased hormonal treatment, which is one of the main treatments for trouble with menstrual cycles. And I'm using a user-centered design to hopefully getting some help from all of you to help providers communicate better about these issues with people who menstruate and how to make their lives better. So just to really briefly review the other types of contraception and how they may apply both generally and in sickle cell disease. So long-acting reversible contraceptives include both IUDs and implantable contraception. They're generally the most effective methods in preventing pregnancy. They're also the safest with a lot of the fewest side effects, including no estrogen, which is the culprit in the increase in blood clots. Also, there's low rates of contraindications in general. People tend to be satisfied once they get it, more than short-acting methods, and continue it. They last a lot. They can last a long time. They can have rapid return to fertility. They can be cost-effective and are less likely used by teens because of that sort of investment in the insertion of the device, and also sort of the complicated messaging around them. So just to review briefly, the next one on the contraceptive implant is progestin-only method that is approved for up to 3 years, but it's been proven effective for up to 5 years. So that's usually how long we leave it in, or until somebody wants it out. It inhibits ovulation. The bleeding pattern with it is irregular, and bleeding is usually one of the reasons hormonal contraceptive is recommended. So that can be a little bit tricky. About a quarter of people have periods stop. It does improve period cramps and heavy bleeding in a larger amount of people, and about 1/10 of people discontinue use of it because of the irregular bleeding with it. So then moving on to the intrauterine device, the levonorgestrel IUD or the progestin IUDs, or intrauterine systems or intrauterine devices. Mirena and Liletta are the ones with the highest dose of progestin, and then there's sort of a medium dose with Kyleena and Skyla, which lasts less time and has lower dose of progestin, so more likely to have some bleeding with it. They have a steady dose of progestin that is localized to the uterus, and they can be used for up to 8 years effectively. And a doctor does need to insert them and remove them in the office with significant discomfort and pain. Some places, like we often will do it under sedation if somebody desires that. Most will cause irregular bleeding initially, but in 90% of people, periods become lighter with the Mirena and Liletta. And in about 1/3 of people, periods will stop altogether, which is sometimes beneficial.
Maayan, can you put this in presenter mode?
Oh gosh, thank you. That's embarrassing.
Okay.
Thank you. Thank you for alerting me. Gosh, you saw my secret notes. So the copper IUD is a non-hormonal method. It works with copper ions and can last up to 12 years. it can also work as emergency contraception. It causes bleeding to be heavier, longer, and crampier. I don't know why this says for the first 6 months. That's an error. It's pretty much for good during the duration of it. So it's often not ideal for people with heavy bleeding or painful bleeding, and very rarely desired in teenagers as a result. So I'm really briefly going to overview the non-hormonal methods. This is the internal condom and the external condom, formerly known as the female and male condoms. Basically, it's applied to the penis or inside the vagina right before sex, and it's for like one-time use. It's the only way to prevent sexually transmitted infections, as well as being okay for pregnancy prevention, but beneficial in a lot of other ways. I forgot to put a male sterilization picture up here. I apologize about that. Being an adolescent medicine doctor, sterilization is not my strong suit, and I will let Dr. Roe answer any questions about those. I have no financial interest in bedsider.org, but I recommend it to everybody. I feel like it lays things out really nicely. They have other sexual and reproductive health tips and like a guy's guide with like videos and just a lot of really nice guidance. And they have like Q&A videos, and like you can sort of scroll through and explore things really nicely about different types of birth control. So I would recommend that to get information in your own pace about birth control. So then when people are asked about what birth control they want, how do they choose and how do we present it to them? I think a lot of times people are sort of given an entire menu of options, and it sort of feels like you're in the cereal aisle. It's like, I don't know, this looks good. Like there's not too much sugar in it, and it has whole grains, and like I think it'll do what I need it to do, but they all kind of seem the same, and I don't know what's going to be good for me. And it's really hard when your like hematologist is not necessarily like gearing this like as knowledgeable about the information, or if your primary care doctor doesn't really understand what's best for you as someone with sickle cell disease or like as a person. So I want to know how people are thinking about this to better present the information to them. And I asked them who they want to talk to about this. And generally, people generally preferred their pediatric hematologist in this 12 patients that I asked before COVID. And a few, and almost as many, 3 out of 12 preferred their PCP, and most of them did not answer. And then the 12 people that I asked, 3 of them were prescribed birth control, and 1 of them was sexually active with no birth control. So that's sort of a missed opportunity, which made me want to ask more people more of these questions, a lot of questions around them as to like what's going on with how you decide about birth control. So more data to come around that, which is a topic of my current research. So just to review a little bit, I published a study in 2021 of providers recruited from the American Society for Pediatric Hematology Oncology interest listserv, and also from program directors, and 92 providers completed the survey, 77 pediatric hematologists, 12 adult, and 1 med peds. Found and asked them a bunch of questions, including how important do you feel sexual and reproductive health care is for your adolescents or young adults, sickle cell patients? Should this be standardized in sickle cell centers? What do you want to discuss with parents and what without them, including contraception? And then do you have a preferred method of contraception for pregnancy prevention for your sickle cell patients? And so most providers didn't, and then we asked them separately if they thought that combined hormonal contraceptives like with estrogen were acceptable for birth control. And about a third thought they were acceptable. And a fewer for the patch, and and about a third for the ring. And there was no difference between pediatric and adult providers, which was pretty interesting. And then we asked them separately if combined hormonal contraceptive with estrogen should never be used. They were pretty ambivalent about it. 38% disagreed, 30% neither agreed nor disagreed, and 5% strongly agreed, 9% strongly disagreed. So there's no clear consensus on like, is estrogen okay or not, which I think speaks to sort of like the like unclear nature of like blood clots and individual histories. And they said like if there are no other risk factors, there was sort of a split as to like 47% agreed, 4% strongly agreed that people can use combined hormonal birth control, 4% strongly disagreed, and 17% disagreed. And a third neither agreed nor disagreed. And then separately, they asked about pregnancy. Is it high risk in anyone with sickle cell disease? And 46% said strongly agree, 41% agree, 8% said neither agree nor disagree, 4% said disagree, or 1% said strongly disagree. And just to plug that pregnancy can be safe for women with sickle cell disease, and needs to be sort of thought out, or it needs to be thoughtful and discussed, I think, especially if people are on teratogenic medications. And it's up to the person. So then asking the providers a little bit more details about what they thought. And we got a lot of quotations from them that I won't share all of them. Basically, they said, I think it would be a stretch in my imagination that pediatric hematologists will be learning how to put in subcutaneous implants or IUDs. And then I tend to steer away from estrogen if we can, but then I also remind them that pregnancy is a higher clot risk than a lot of birth control pills are. So it depends what your weight is. They discussed family decision-making. They discussed dysmenorrhea, fertility, priapism, thrombogenicidity, and breastfeeding, vaso-occlusive crises, and sexual function as the key themes on the context of the mortality benefit of contraception. So in conclusion, people with sickle cell disease deserve individual contraception considering historical trauma, interaction with their individual disease process, increased menstrual concerns, perinatal risks, and healthcare limitations and connections, and their individual needs and desires. And I think this is where I'm going to hand it off to Dr. Roe, if that is all right.
Thank you so much, Dr. Leroy-Melamed. I really appreciate it. That was such a great overview. And at the end, we're very, very happy to take any questions about any individual methods. And we know this is like such a whirlwind and the information can be confusing because sometimes there are no clear-cut answers. So very happy to talk this through and dissect a little bit more if you guys would like. I'm just going to spend a few extra minutes talking more about periods and how that relates to contraception, and then also some current research in those areas. So first, you all might be aware that periods can be a really difficult time for people with sickle cell disease. Over half of people with sickle cell disease who menstruate report dysmenorrhea, which is basically just another way of saying painful menstrual cramps. And that's something that many people experience and is a little bit hard to measure. So it's hard to know how many people in the general population have dysmenorrhea, but certainly over half of people with sickle cell disease report it, which is a lot. And then over 1/3 of people who menstruate with sickle cell disease report sickle cell pain crises that are actually associated with their periods. So occurring either with their periods or just beforehand. And then importantly, in this diagram that you can see in the middle of this slide, people with sickle cell disease are really able to distinguish pain that is menstrual related, so just menstrual cramping, from their sickle cell pain. So basically in this study that was done by Dr. Diva Sharma, people were asked basically about menstrual pain and about sickle cell pain. And you can see that some people reported dysmenorrhea only, and some people reported menstrual related sickle cell pain only, and then some people reported both. But what this showed is that people are really able to distinguish. And maybe that's not, that's obvious to a lot of you guys, but this is just to say that there are different kinds of pain, and these are distinguishable probably primarily just by location. So sickle cell pain may occur in sort of typical spots in the body, whereas menstrual cramping is obviously going to be sort of close to the uterus and in the lower abdomen or pelvis, and just feels different. And so the thing about this is that as of now, it's unclear whether hormonal contraception can affect pain associated with periods. And I'll get into that a little bit more on the next couple of slides. If you could advance one. So just to take a step back here, sort of one way that I have became very interested in this, and I think is like really interesting to remember, is that when you look at sickle cell pain rates between females and males with sickle cell disease, you can see that females actually experience more frequent pain episodes, especially during their reproductive years, which are the like middle of this slide where the peak of the curves are located. And that's, you can see that the females have more pain episodes per year than the males. So the dark gray versus the lighter gray. And in addition, not shown on this slide, but in other studies, they actually report more severe pain during those episodes compared with males. And in addition, also not shown on this slide, but in another study, people who report menstruation-associated pain crises, so pain crises that are triggered or come along with menses or their periods, they are hospitalized more often than those who don't have pain crises associated with menstruation. And so this makes me think that maybe some of the difference in these pain outcomes that we're seeing here and in the other studies I just described, maybe they are in fact due to menstruation-related sickle cell pain. So that's sort of one way of framing this that I think is really interesting and just sort of highlights how important this is. Next slide, please. So this leads us to wonder, right? So if menstruation is related to or increases sickle cell pain frequency, is there any way that we can modify menstruation to improve or avoid the sickle cell pain that it sometimes triggers? So separately, like we just heard about, hormonal contraception is very, very helpful for dysmenorrhea in the general population. So if you get cramps around the time of your period and you go on the birth control pill or the hormonal IUD, that painful period or dysmenorrhea is going to probably go away or at least get a lot better. That's almost always true. But what about the relationship between hormonal contraception and the sickle cell pain? Is that going to be the same thing? And so there was a very old study, and you can tell that it's old because this is like a Xeroxed, very faded graph. That is the best version of this graph that we've got. But in this old study that was done, pre-2000, they saw that medroxyprogesterone or Depo-Provera, which is that progestin contraceptive injection, was actually associated with a significant decrease in pain frequency in females with sickle cell disease. And that was compared to people who used no hormonal contraception. So over time, so everyone started at that dot on the left, and then over time they were followed out. And basically the people who had the lowest level of pain episodes by the end of the study were in that lowest line, and those are the people who were using Depo. And so this really suggests that maybe Depo had a positive effect, had improved this pain. And you can sort of make sense of this, right? So if people are having ups and downs with their hormones in their bodies, and then Depo is an injection that actually tells your body to stop creating all of the sex hormones that cause you to menstruate and cause you to ovulate and do all those things. If all of those hormones get kind of flattened out and stay low, maybe you don't menstruate, and maybe those hormones aren't fluctuating and getting high, and maybe that's why you don't have pain. But this is all sort of like us trying to understand this. And like I said, this is a really old study. So if you can go to the next slide. I'm actually really interested in replicating that study in a modern era. But, 1997, I don't know, to me doesn't sound like that long ago, but it really is. And lots of medications have changed, and people with sickle cell are using different medicines than they were before. And I think that there are sort of better ways to do that study. So I'm going to tell you that the fourth bullet point that I have on this slide is actually a study that we just got grant funding from the NIH to do. So we are looking at people who are not using any contraception for 3 months, and then we're going to ask them to use Depo for 3 months. One injection actually just lasts 3 months. And then we're going to compare before and after and see, does the frequency of pain episodes change? We're also going to do blood work and say, like, do certain biomarkers that might be associated with pain crises, are those different? And so stay tuned. It's a 4-year grant. So I'll let you know how it all goes in a little while. But in the meantime, we're doing some other studies too. I'm actually going to work backwards from the bottom there. The Nexplanon study, that's the contraceptive implant that goes in your arm. And that I'm doing a very similar kind of study on. So looking at people at baseline and then placing a Nexplanon to see if that actually helps with pain at all. It's never been studied. We really just don't know. And so that's something that I'd like to know a little bit more about, because we just don't have any modern information on whether hormonal contraceptives have any effect on pain. And then in the first 2 studies that you see listed on those bullet points, we're looking at biomarkers in the blood. So factors in the blood that may change during pain episodes versus at baseline when there's no pain. And we're looking to see if that's different. They're definitely different between having a pain episode and at baseline. That's known. But we're looking to see if it's different between females and males. So like, when a female individual has a pain crisis versus a male individual with sickle cell disease, do those blood factors look different? We just don't know. It hasn't really been broken out by sex like that before. And so we're interested in that. And then for the second biomarker, I don't know why I'm going totally out of order here, but just to keep everyone, awake here. For biomarkers across the menstrual cycle, what we're doing is we're looking and seeing those same biomarkers that I'm looking at in bullet number 1. I'm seeing, do those change over the menstrual cycle? And might that be associated with higher risk of a pain crisis, say around menstruation? So if there are certain blood factors that kind of go up around that time, just naturally, maybe that can be an explanation for why things are happening at certain times of the menstrual cycle. And that's really not been looked at. And we know in the general population that lots of things change across the menstrual cycle that may not be significant, but maybe for people with sickle cell disease, that is more significant. So stay tuned on that. Lots of interesting things for us to look at. So I think in general, I just feel like this is a really exciting time for sickle cell disease and reproductive health. I think sort of unfairly, it hasn't really been looked at, and that really shortchanges people with sickle cell, and especially people who menstruate, because there's so much sort of pointing towards, interesting things and problematic things happening around menstruation, and yet we still don't fully understand it. So I'm hoping that over the next few years, we're going to really understand a lot more and get information that can help you guys make some decisions about your health care. So that's what I've got to say on that.
That's amazing, Dr. Roe. We're really excited about the research that you two are doing. Oh, there's your references and some.
Oh yeah, these are our. I hope you can see these QR codes. But if you guys want to participate in any of our studies, please grab a little shot of those QR codes and be in touch. If you're in the Philadelphia area for me, and can you do yours?
Mine's remote.
Remote, yes.
Anyone can
anywhere.
Yes.
Yeah, perfect.
That's awesome. We will make sure to include these in our email blast when we send out the replay video as well.
Awesome. Thank you.
Let's get into some of these questions.
Please.
It just really resonated with me, the whole presentation, but particularly when both of you kind of touched on the toll that your menstrual cycle can take. I remember back in high school, before I got my IUD, I would literally have incredibly heavy bleeding, horrible cramps. I remember one time, like, just being on the bathroom floor in my school, and it would always send me into a crisis. So I would miss like a week of school every month because of it. And it did not change until I got my IUD placed. But I do have someone watching who is saying that she has a progesterone only IUD right now, and she still is having heavy bleeding. So what should her next step be?
I guess I'll start by saying, I'm sorry, that stinks. The hormonal IUD is an approved method for heavy menstrual bleeding. And it has not been studied specifically in sickle cell disease, to my knowledge, which makes it a little bit more difficult. Also, if you have sickle cell disease and are on a blood thinner for some reason, that may make it more challenging. I think there are some people who may benefit from estrogen on top of the IUD, and I think it's really on a case-by-case basis, and really depends on like what other medications people are on and stuff like that. So definitely talk to your doctor. I don't know if Dr. Roe, if you have anything else to add about that.
Yeah, I had totally the same thoughts. Like, sometimes what can happen is that despite the hormonal IUD, you can have heavy bleeding, especially in someone on anticoagulation medication. So if there's like a history of a blood clot, for which there's medications that are being taken, that can often account for that. And so that's going to be a conversation probably with, between the individual and, the provider who's, managing the IUD, and probably the hematologist as well, to decide, is estrogen something that is safe to do on top of it? Are there other medications that can be used to reduce menstrual flow, like tranexamic acid? The other thing to think about is that sometimes there can be other sources of bleeding that are just not necessarily hormonal. So sometimes it might be helpful to get a pelvic ultrasound. So it a little bit depends on the specifics of the situation, I think, but probably conversation, ultrasound, maybe new medications are going to be the right step. Next step is going to be in there somewhere, I think.
Okay, thank you for that. I think you touched on this at the beginning, but is there any research showing that progesterone-only birth control pills are better than combo pills?
It depends on better for what. I'm trying to think of what better necessarily means. So if we're talking about pregnancy prevention, or if we're talking about for menstrual treatment for like heavy menstrual bleeding or for painful menstrual bleeding, it depends. Is there clarification? I'm just
Let's do both.
I could talk about all the above. When it comes to pregnancy prevention, the studies on progestin-only contraception are sort of mixed together with the combined ones. So when you look at the labeling, it's all somewhat together. So they're labeled as being as effective for pregnancy prevention as each other, the same effectiveness rate, which I want to say is an 8% failure rate. And Dr. Roe, you can please correct me if I'm wrong.
You got it.
Thank you. And so I think that clinically, most people consider progestin-only pills to be less effective than estrogen-containing pills. And especially because of the timing, progestin-only pills are labeled to be taken within a 3-hour period. And because they have like a little bit less of a fail-safe in the estrogen preventing the ovulation, they're relying on the progestin to help with mucus and stuff like that. And depending on the progestin and its half-life and stuff like that, it may or may not be more of a problem if it's taken outside of that 3-hour window, whereas the estrogen containing pills are thought to have more like a 24-hour window. But really not super well studied. And it also depends on which progestin only pill and which estrogen containing pill and stuff like that. So I think there are a lot of different factors in terms of pregnancy prevention. When it comes to predictable bleeding, that can be something that estrogen can be helpful for. That's part of the reason why estrogen containing pills can be more common than the progestin only pills. I think that with new progestin only pills also that are coming out that may be changing. And I know OBGYNs that are preferentially prescribing progestin only pills because of that decreased risk of the estrogen, and just have a preference for the progestin only pills because they work as well for most of what people are using them for. I think I interpreted better in any way that I could. Dr. Roe, can you fill in any gaps I may have missed, please?
Yeah, the only thing, I completely agree with you, but I thought the same thing. Better how? What do you mean by better? Better is in the eye of the beholder, right? I think that you're exactly right. And just to reiterate, sort of the effectiveness of a method at preventing pregnancy is often reliant on the individual taking that medication, right? Just like any sort of other medication, like it works if you're actually taking it. And pills, daily pills, are really hard to take and easy to forget. And so in that respect, that's why pills are not as effective, we say, as like the IUD, because the IUD, you can't forget to take it because it's always there. But that doesn't mean that, that doesn't mean that you necessarily want an IUD, but that's just one sort of row of all the different things that you're thinking about. That's one of the factors that you're considering potentially. And so when you think about the effectiveness, the combined pill, and when we say combined, we mean estrogen plus progestin versus the progestin only pill that doesn't have estrogen. Those two we think are probably different. Because if you forget the progestin only pill more, it doesn't work. It works even less well, probably, because you can't make up for things quite as much. However, I will say that there is a new progestin only pill that's on the market, and I don't work for this company and I'm not promoting it in any way, but the brand name is Slynd, SLYND, and it's a drospirenone only pill. And that's drospirenone is found in other combined pills. But what's nice about this new pill is that it actually does suppress ovulation. So whereas the classic progestin only pill, which I don't know, we call like Micronor, or some people refer to it as the mini pill. Bless you. It's a different hormone. And that one only works by the cervical mucus thickening and all those things, but you're still ovulating. So you're still doing other stuff that could potentially put you at risk for pregnancy. This drospirenone pill does the cervical mucus thickening and it prevents ovulation, just like the combined pills. So it feels like that one should work a little bit better, but there have not actually been any head-to-head comparisons of the two progestin only pills that are on the market. But if you can, if there are people who are having, who need a progestin only pill and would really benefit from that suppressing of ovulation and, the other things that that pill comes with, I really, strive to get the Slynd for them. However, that's a little bit of a hard, it's not always covered by insurance, I think, because it's lumped together with this other progestin pill that's really inexpensive. So sometimes it requires a big conversation with insurance companies and things like that. But just to know that this other one is out there, and just because, the typical progestin only pill didn't work for you or you had side effects, just know that there's this other one out there as well that you could ask your doctors about.
I also want to add, we talked about the two types of progestin only prescription pills, the mini pill and which is norethindrone, and the drospirenone, and the over-the-counter pill is the O pill, which is I'm totally blanking on what the progestin is.
Norgestrel.
That's what I thought, but then I was like, is that right?
I know.
Okay, it's norgestrel, and it's thought to work more similar to the mini pill, which is the norethindrone. So it's not as it doesn't have like a placebo couple of days. It's doesn't control bleeding as well as the drospirenone. It doesn't prevent ovulation as far as we know, but it is available over the counter and you don't need a prescription for it. And I'm trying to look back at my slides on the ratings and confirm that it is a 1 on the, it is a like generally low risk option for sickle cell disease.
Wow. Okay. That's all so fascinating to me. I haven't really been keeping track of like the different pills because in high school I did get on a birth control pill for bleeding, and like Dr. Roe said, I was forgetting to take it, and I was still having bleeding. And then I also did get my first pulmonary embolism. So I got my IUD and it's been the best thing ever. But there are some questions, just kind of wanting to know, like, this is a lot to digest. It's kind of overwhelming. So I know, Dr. Roe, you already spoke about like shared decision-making and the importance of multidisciplinary care. But I'm curious to know from the two of you, what other advice would you give to warriors and their caregivers about how to navigate and kind of figure out what method works for you?
I think that I tell all my patients, and this isn't like a super fun answer, but the reality is that sometimes it takes a little bit of trial and error to find the method that's best for you. A lot of people don't find the method that they like best on their first try. Ideally, that's not because you get a pulmonary embolism. Ideally, it would be with a little bit more like, shared decision making with less risk. And also like part of shared decision making is like knowing risk and understanding those things together. I think that like going on websites like Bedsider, the CDC has a website on different methods of birth control, learning as much as you can about the different methods, like talking to friends and stuff like that about their experiences, as biased as that might be. At least it's like giving you information, and it's somewhat taboo to talk about sometimes. And I think it can be helpful. And I think like bringing it up to your provider, and I think it depends like who your provider is, like what information you could bring to them. Like that's part of the work that I want to do, is like having the provider have guided information, like if it's a hematologist, giving them the information about the different types of methods to best be able to have those conversations with people, and giving PCPs the sickle cell specific information that's helpful. And just being as informed as you can, and knowing that so no method has been proven to cause long-term infertility. No method is more dangerous than pregnancy. And like, I don't want anyone to take any unnecessary risks, and have those conversations with your provider. Hopefully that was helpful. Dr. Roe, please.
Yeah, I think that's great. I always say, when we're starting a new contraceptive method, this is an experiment. Like you don't know if this is going to work for you. I mean, we can read about things as best we can. We can ask our friends, we can ask our family. but you won't really know until you try something for yourself. And that's true for so many things, not just
Yeah.
contraception, of course. So I think that that's, it's hard to predict in advance, but you can get as much information as you possibly can so you can make a good and informed decision for yourself. The other piece I'll just add is that, until we have this awesome education that is going to the hematologists and the PCPs and the OBGYN so that everybody is super well informed, I think, individuals with sickle cell, unfortunately or fortunately, have to advocate for themselves, and so we learned in studies, we did some qualitative work, meaning we did interviews for with individuals with sickle cell disease and asking about reproductive health issues and sort of what your experience has been, what your experience has been with contraception, who you heard about these things from, and who you trusted to get information from. And we heard a lot from a lot of people that, people with sickle cell disease were really caught in the middle, right? So you go to your OBGYN and they don't know as much about sickle cell disease as you would hope. And you go to your hematologist and they don't know as much about contraception as you would hope. And so it's, unfortunately on your shoulders to, educate and kind of help facilitate those conversations. And so I would just say, like, don't give up on that. And, maybe make those two people talk to each other. In addition to you being the go-between. So definitely feel empowered to advocate for yourself, to share information, to share what your concerns are, and get everything out in the open so that everybody can help you and make the best decision for yourself.
I love that. And that's actually a great little segue. I'm going to make a shameless plug that I've been working on a project in collaboration with 13 different providers across many disciplines. And we've been coming up with this reproductive life manual because it is just so much to navigate, you guys. And so, when I look back, I wish that I would have had some type of like a blueprint. So over the last 2 years, my team and we've been working on that blueprint, and it's finally finished, and we should be able to publish it at the beginning of next year. So I'm really excited about that. It's gonna include things like overviews, everything from puberty to menopause, priapism. We did not leave the guys out either. And it'll have checklists, like what you need to talk to your doctor about, what you need to talk to your partner about. But as Dr. Roe was just saying, like, it's not fair for all of the weight to be on us. So Maayan and I have been talking. I'm trying to figure out how we can also start doing the same type of thing for providers. And I see Francine has a question related to that, because we're wanting to know, like, are OBGYNs getting any type of sickle cell specific trainings? For how
Is that the question?
Mm,
No.
yeah. Well, have no fear. Like, SC Red is here. We'll work on it.
Yeah. Yeah. I mean, I will say that the CDC guidelines that we, we're learning about and also just recently were updated. Everybody knows about that, or I don't know if I should say everybody, but that is a very well-known resource. And like I have an app on my phone, for example, that has the CDC guidelines. And so what you can do is you can go into that app, and actually it has a list of a lot of different kinds of medical conditions, and it summarizes what those guidelines say. So you could go in, click on sickle cell disease, and then see what their recommendations are. But I will say, even though I, helped and participated in some of these discussions around those guidelines, there's still a lot of nuance that is not captured in a category 1 or category 4, and all the things that we were talking about where, a conversation and sort of putting, your head together with your hematologist and your reproductive health provider, you might come up with something that is, different from the red light, green light recommendations on that app. So I guess I would say that even if we don't receive sickle cell specific training, there is access to things and people know about these resources. But that's not a full substitute for these more nuanced conversations, I think.
Makes sense. And this probably isn't even fair to like ask you this, because I guess you can't speak for like all providers, but I know when I've sat on like committees with NIH or ASH and we're doing guidelines, say for like ER treatment or something, what we find is that a warrior might go and pull the guidelines up, but the provider is really not interested in following them. Do you feel that this is totally different and unique so that the provider's attitude is like more receptive to following those guidelines?
That is so hard to probably speak for everybody.
Right.
Yeah, I think I would just be more worried if somebody were accessing these guidelines that they would just kind of stick to things so literally. So I don't know. Number one, are you even accessing the guidelines? That it's so hard to tell. I can't speak for, all OBGYNs across the country. But I think my worry about something like the MEC guidelines is it's so amazing to have something as opposed to nothing.
Yeah.
But then my worry is that, are people going to just say, oh, pills are category 4, we will never, ever use them. I mean, you saw in Maayan's research that actually a lot of providers feel like there are reasonable circumstances where we could use it. And and it's not like something drastic has changed between that survey and these guidelines, like no new information came to light. And so I guess, I don't know, a little bit of a broken record, I'm sorry, but just, I think that sometimes we really need to make individual decisions and have conversations. And I'm not sure that anything should be like totally off the table.
Yeah.
It's very, very, it should be all individualized.
Maybe SCRED should spearhead like some type of survey because I'm kind of curious to know that. But there's a couple more questions before I let you go. Okay, yeah. So this was actually my question because we kind of covered how women have more pain than men and believe that it's associated with menses. So I'm curious to know, and I think I know the answer. Is there data showing that pain lessens with menopause onset?
I actually don't know if we have that data. It's on my list. If I could show you my list of things to research, it's literally on there, but I haven't gotten to it yet, guys. So, but it would stand to reason, right? But I actually don't know. Do you guys know? Have you asked other people about that? I know menopause is far from Maayan's.
Yeah, I was really hoping someone else had the answers.
Well, no. So I asked a few when we did our like fine wine panel. It was all women over 60, and it did seem like pain decreased due to menopause. So that's amazing. I know that Dr. Pecker, when she and I first got started along with Dr. Smith-Whitley, I asked to see like her research wish list. And so definitely want to see yours too, Dr. Roe.
Sounds good.
Only
if you help me check off all the boxes.
I will.
You should ask Diva Sharma because Diva Sharma is.
Oh, we love her. She's on my medical advisory board.
Yeah, she's internal medicine trained, so I feel like you should know. Maybe it's actually. I haven't listened to the whole podcast that I posted in the chat, but I bet you the answer's in there.
Oh, okay. I think you put it in the private chat, and I forgot to put it.
I don't know how to make the chat. I don't know.
No. I'll take care of it.
But I can say it out loud. There's a podcast from the Foundation for Women and Girls with Blood Disorders. The podcast is called 721. Again, I have no affiliation or don't get any royalties from this. I'm not even on this podcast. And they did an overview of reproductive health and sickle cell disease in 2-part series with Diva Sharma and Zachary. What's his last name? Andrea, do you know? Oh my gosh. Blanking on his name.
It begins with an M. I'm not sure.
It's okay. I'll put it in. I'll also include it in the email. We can see later.
Ramsey.
Thank you.
Oh, cool.
And they, have a 2-part series on reproductive health and sickle cell disease. So if you want more information, it's a good place to start.
Yes, and we do have plans to partner with the foundation on the reproductive life plan. Wow. Okay. So there's this question from Francine Baker, who's this incredible caregiver, researcher. I love her so much. And so she has a question for you, Dr. Roe. And I wish she was on here because I don't even feel smart enough to ask this. For your Depo study, are you looking at the microbiome, either the gut or vaginal microbiome, and how changes may impact the effectiveness of contraception as well as associated symptoms?
Fascinating. I am not looking at either of those things, but I would love to know more about how you think they might change. That's really interesting. But no, we're looking at just self-reported pain outcomes. So, individuals telling us how, when they're having pain episodes, et cetera. And then we're doing blood draws. So just blood biomarkers.
Okay, cool. And I know that Francine is currently at Penn, so maybe that's a collab.
Francine, my new BFF. Let's
Exactly. Okay, I think that maybe was the last question. It looks like just a lot of comments, just kind of saying that this was an incredible conversation and we learned a lot. So I appreciate you guys. Oh, no, one more question. Oh, two more questions. Sorry. Okay, so it's really interesting. I don't know if you guys have seen that there is a series that Stat News is spearheading after having some conversations with people like Dr. Pecker and myself, all about like coercive care, right? And one of the findings was that women with sickle cell, which we knew, but it's just heartbreaking to see it in black and white, that they have been pressured into things like tubal ligation, right? And told that they should not have kids, can't have kids, too dangerous to have children. But then on the flip side, we do have some people who have come to us to say that they are at a place where either just because of like the bleeding and the pain or just not wanting to have children, they want tubal ligation, but their doctor will not do it.
You mean a hysterectomy?
Yes. A hysterectomy and tubal ligation. So what are your thoughts on those?
Andrea, I was hoping you have an answer because there's an organization that like has a list of providers that basically won't give you a hard time about her hysterectomy. And I'm going to see if I can find it.
Well, I can talk while you're looking that up.
Please.
I would say, I think that I can totally see this, like with so many things, there's sort of this pendulum, especially with reproductive health care, where people get really excited about a method. And then you find out, oh, whoops, healthcare providers were not as thoughtful as they could have been. And sometimes are downright coercive. And then there's sort of this swing in the other direction to try to compensate for that. And I think that people should always be able to find somebody who can, provide them with the care that they need. Like it's a little bit, I don't know, I guess it's a little bit disempowering for a provider to decide like in either way. I mean, a provider can say, I don't feel comfortable doing this, right? Like they're a person just like anybody else. And so if there's something about, a procedure or something that they, are not equipped to do for whatever reason, they're allowed to, but you're also allowed to just go somewhere else and find somebody who will, sort of listen to you and your concerns, and talk with you, to find, the right thing for you. And I would say it doesn't feel like it should be that hard to find somebody who would be willing to talk with you. Sometimes people, you want to hear about what have you tried and all of those kinds of things. But a similar thing has happened just sort of separately with tubal ligation, or we call it self-injectomy now, because usually people are removing the whole tube, not just sort of cutting the tube or burning the tube. But usually people are just removing the whole tube, which is basically a very similar type of surgery. And there used to be a lot of concern about providing that type of permanent procedure to younger individuals, and so providers would say, oh, you might regret this later. I don't want to do this for you because you're only, in your 20s. And what if you change your mind and want to, have a baby in a decade? And so these conversations are happening in lots of different ways, I guess, is what I'm saying. With reproductive health care. And so you're going to find people who, might not think the same way that you do. And then it's your prerogative to go find somebody who will listen and get you what you need.
Okay. And as a follow-up, say that someone is like 100% certain that they do not want to have children. Would you advise that they get a hysterectomy, or would you be worried, like medically, that going through that invasive procedure is not healthy?
I would say it's not typically the first step because it is a major surgery and there's so many other things that are less invasive and therefore less risky.
Yeah.
But there might be other reasons, like you said, for pursuing it. So it's not just contraception, but it's, and I have fibroids, and these fibroids have been plaguing me for my whole life, and I'm done with them. And so there might be other reasons why a hysterectomy makes perfect sense. But I would say for just contraceptive purposes, it's not usually the first thought because it is, a big surgery. But there might be other reasons that make it kind of like go to the top of the list because you have other medical conditions or you've tried everything else and that didn't work, or something like that. So I think that it would be a reasonable conversation, but usually not the first thing that people think of.
Okay. And Constance, I see your comment saying that this was a great discussion, but you would like to have a conversation on fertility and infertility. So I don't know if you know my story, that I actually had a bone marrow transplant about 12 years ago, a haploidentical transplant, and went into my consult saying, like, I'd be willing to risk anything to be cured of sickle cell, even death, but I don't want to be infertile. So not having access to grants and like policies in the way that oncology patients do, not getting a fertility consult, just not seeing anything specific to sickle cell and fertility is really the inspiration for starting this organization. So if you go to our website, we have a playlist of all of these critical conversation webinars that we've done in the past. And we did, the first one that we did this year was with Dr. Lydia Pecker, who's one of my co-founders, and Dr. Kate Vaught, who is a reproductive endocrinologist on infertility and fertility. And they also did speak about IVF. And before the year is over, I do have somebody else coming to do a session on IVF with PGT. And those things have historically not really been accessible to this community because they are incredibly expensive. But that's something that I am working overtime on, is making access to fertility services and IVF with PGT more affordable and accessible. So you can check out the website and hear that. We also just did a live event in DC just on fertility as it relates to individuals with sickle cell disease that you can also find on the website. And then Deirdre, your last.
I can mention the website if you'd like.
My website?
No, you should definitely mention your website. The answer to the question about the hysterectomies.
Oh, go ahead.
So I want to couch it with saying that, like, I think that nobody should be shamed about their reproductive decisions. And that's sort of what this is all about. If you're looking for contraception, you should be getting the information in a way that is like personalized to you and what you are looking for. And if you are looking for fertility or infertility information, you should be getting that information without feeling shamed. And people with sickle cell disease should have access to fertility preservation. I just want to like give all that as a preamble, given the like historical coercion around either direction. And so people, I think, should anyway. So the list of it's from Reddit, I guess, that I found. It's like Reddit. If you look up Reddit child free, like Reddit child free doctors list, it comes up with a list of doctors that will perform hysterectomies in younger people, young adults, without shame.
Nice. Okay, so this is the last question. And thank you guys for being so engaging and having such a robust conversation. This is really nice to see. So Deirdre, she had an experience where she received like multiple doses of Depo, and it wasn't until her third shot that it actually made a difference in reducing the pain. Is that common?
Just to go back to the pain in menstrual cycles, I know this is something that Dr. Roe is studying, and it's something that's being studied by some other doctors, and I am following that research closely because I'm doing research around it, but not exactly on it, understanding like exactly what part of menstrual cycles are causing increased pain, and that's not like definitively understood yet. So that having been said, in general, when we administer Depo, we expect there to be a lot of irregular bleeding during the first 6 months or so. And so like it is not uncommon in the general population for people to have irregular bleeding until the third injection, and then for things to become a little bit more stable and for people to have no bleeding or amenorrhea as a desired side effect. There is some evidence that prostaglandins, which are released during periods, and they're sort of like a feedback loop from bleeding, that prostaglandins cause more cramping and pain, and then that pain feeds back with the bleeding, and that has something to do with the increased crises. So it would make sense to me that if there was more irregular bleeding until the third round of Depo, then that might be part of the cause. That was a really roundabout answer.
Thank you.
Dr. Roe, I don't know if you have anything else to add to that.
I think we just don't, I think at least what I can't figure out yet is if Depo is going to work. What I don't know if it's, through what mechanism. So if it's, the fact that it suppresses ovulation and it kind of flattens out your normally cycling hormones, then that happens quickly. If it has something to do more with the bleeding, then that might not happen as quickly. And I think there might be other mechanisms too that we are not even thinking of. So I don't know. I just don't know. So we'll see.
There's a lot of gaps, you guys, but we're really grateful to providers like the ones we have with us tonight who are working to address these knowledge gaps. And we will definitely make sure to bring them back so that we can get updates on their research. And I know, Maayan, like you're going to be doing the interviews, and we'll just keep on sharing these because we really, they cannot do this work without including the warrior voices. And so it's going to be really important that when we push these surveys and these interviews out, that we get your guys' participation. So we'll make sure to keep you in the loop as those opportunities become available. And thank you all so much. This was incredible. I'm going to let you two have the final word. If there's anything else, any takeaways that you want to leave the community with.
I just want to say thank you so much for having us. It's really an honor, and love talking with you guys and hearing everyone's ideas. I think that it's really helpful to us to know what's important to you, and we just appreciate your partnership.
Yeah. In addition to the study of adolescents and their parents, I'm also like the Career Development Award that I mentioned has a user-centered design approach. So like having you guys participate and design the research to make it focus on what you need and want most. So I really appreciate you being here today and like asking the questions, and I learned so much from you all, and I look forward to working with you more in the future.
All right, awesome. So we are going to take a break. I know I usually do like 2 of these a month, but it's SCDAA. So we're not going to do one. This will be the only one this month, but we will see you next month. So thanks again for joining.